All right, folks, so there's a kind of a hush falling over the room. I know a few people are still coming in, but I think we should get started. So excited to hear from our panel tonight. So good evening and welcome to our panel, Prescribed Safer Supply, History, Evidence, and Politics. We meet in unceded territories of the Mi'kmaq, Wolastoqey, and Passamaquoddy peoples, sovereign nations holding inherent rights as the original peoples of these lands. And we convene our panel tonight with respect and gratitude for the first peoples of these lands. And we reflect on the inherent rights of the first peoples and our collective obligations under the Peace and Friendship Treaties and Section 35 of the Constitution Act 1982. We reflect, too, on the profound fact that African Nova Scotians are a distinct people whose histories, legacies, and contributions have enriched this part of Mi'kma'ki known as Nova Scotia for over 400 years. And these are facts, histories, legacies, the legacy of colonialism that, of course, we carry forward into the present and into our engagement with the panel tonight as we think about the losses and the harms of the toxic drug crisis. So I'm Sheila Wildman. I'm Associate Director of Dalhousie's Health Justice Institute. That's an initiative that brings together the faculties of medicine, health professions, and dentistry, as well as law, here at Dalhousie. And tonight we're really spotlighting the first three of those faculties: medicines, health, somewhat dentistry, I guess, but they're somewhere. In recognition that, sometimes, maybe a lot of the time, law gets in the way of justice. I'm also co-chair of East Coast Prison Justice Society, which is the other organization co-hosting tonight's panel. So I'm kind of wearing those two hats. East Coast Prison Justice Society is an organization that brings together lived experience experts and others to advocate for justice for criminalized and incarcerated people, including equitable access to the social determinants of health and justice. Again, it's a collusion of organizations and ambitions that comes together to to convene this conversation tonight. It'll start with some presentations and some background from this incredible panel of experts, local as well as global, that we have right here in our midst. So we'll be learning from the many diverse experiences of our panel. And then we do hope to open up a conversation after maybe 45 minutes or so. So we're really interested in your reflections, your perspectives, and sharing at a time when, back to the harms and the ongoing losses to the toxic drug crisis, this is a time to come together and talk about the facts, talk from experience, listen to the voices of experience, and try not to get lost in the politics. So with that, I'm going to turn it over to our panel, and everyone's going to introduce themselves just really briefly. We have Dr. Tommy Brothers, Dr. Leah Jones, we have Dr. Mike Ginjavik, which I was practicing, and Dr. Mike Ginjavik, now I've got it. Wonderful Matt Bond, who I was just looking at a paper I signed my public health law class. Some of those folks are here, and it's like probably the most cited person in that paper, which was written by law professors, is Matt Bond. Multiple contributions to the literature in this area. And finally, Dr. Leah Genj. So I'm going to leave it to you guys to figure out how you start. I'll just let people know there is a video being made tonight. It's not focused on you, and I'm going to ask the panelists that if somebody asks you a question, would you mind repeating it into the mic so that people watching the video have a sense of what that was? Okay, that's it. over to, I'm not sure who is starting.
It's me. Do you want to introduce the talk?
I'm going to get out of the way. Yeah, yeah.
Are these on, or do we have to turn these on for the
That would be, yeah, they're on. I guess they're on all the time.
It's just for the video.
Why don't we introduce ourselves first
Okay.
before the talk? 'Cause we're gonna
us.
share stuff. Okay, I'm Tommy Brothers. I'm a physician and epidemiologist here in Halifax. I practice addiction medicine and internal medicine. I have some professional experience prescribing safe supply during COVID times while I was doing my PhD, and then since then I've gone back to finish my clinical training and work in the hospital now, so not currently prescribing safe supply in the context we're talking about it today, but involved in lots of research as an often collaborator with Matt as well, related to safe supply, epidemiology, drug policy, all sorts of stuff.
And so I'm Leah Jones. There's two Leahs here tonight. I'm a family physician, and I practice addiction medicine as well as primary care, specifically for Black women and Black community through the Nova Scotia Sisterhood. And my experience, I've had about 2 years of prescribing safer supply in Ottawa from 2021 to 2023, and I'm bringing that experience to this talk right now. I also work with most of the team members here on the inpatient addiction consult service, and we do a lot of harm reduction prescribing in that setting, and I work in Direction 180. So happy to be here.
I'm Mike Gniewicz. I am also a family physician, born and raised here in Halifax, and continue to work here. My primary place of work is at Mobile Outreach Street Health, MOSH for short. It's a program of the North End Community Health Centre, where we provide primary care to people who are vulnerable, living in our community, who are unhoused, living in shelter, or precariously housed. As part of that program, myself and Dr. Gensch, Leah, I've never thought of that before.
A little nervous today.
How formal we are. Together we co-lead the MOSH Safer Opioid Supply Program, and which also includes stimulants. Other than MOSH, I work as a member of the Inpatient Addiction Medicine Consult Service, providing some addiction medicine at Direction 180, as well as a couple other side clinics here and there where I do similar work. Great to meet everybody. Thanks for coming.
And my name is Matthew Bond. I'm someone who uses substances and experienced a lot of the harms related to the toxic drug supply. But I also do a lot of community-based research. My main affiliation right now is Changemark Research and Evaluation out of Vancouver, BC. And I consult on a lot of different projects with them. But I'm also leading some research out of Vancouver on why people are transitioning from injecting to smoking. And that's a project that I've been able to lead with some great mentors and supervisors. And yeah, I have all kinds of different affiliations, and I don't want to overwhelm everybody with those, so I'll pass it over to Leah.
Here all night. I'm Leah, family doctor, and work with Mike at MOSH, and have always practiced in, I guess, the 11 years that I've been practicing, always served people who are experiencing homelessness or street involved. So Mike and I co-lead the Safe Opioid Supply Program. We also co-lead the Managed Alcohol Program, if that's of interest to anybody and they want to chat later. Work in the inpatient addiction consult service, do some community OAT, work in a few other spots. That's it for me.
Can I just ask a question before? Can people hear okay in that?
No, not at all.
Okay, I thought maybe not.
Okay.
So,
Yeah.
Come
I think
sit
you're
up.
going to have to really project.
Or you, people could come closer.
You could do that too, but yeah.
I know.
Well, is there a microphone, or is it just up there?
You could, while you present, you could always stand up that mic, which is
Sure.
loud.
Yeah, let's
I don't
do
know
that.
if these ones aren't.
Start?
Yeah,
Sure.
very well,
Yeah, okay.
unfortunately.
I'm the
Thanks,
Seinfeld.
All right. Is that better? Yeah, that's much better.
Really good, yeah.
Okay. I got lucky. I get to go first. So, prescribed safer supply, history, evidence, and politics. So we have a very diverse, wonderful crowd tonight. Hopefully, if I get too medical, or if we get too medical, or if something's kind of not making sense, we are very happy to clarify things. We'll definitely have lots of time for questions at the end. So I'm going to start us off just kind of rooting us in Canada with what's happening currently with opioid use and the overdose crisis. So many people have seen these maps before. This is the first quarter of 2024.
This is 2023.
Oh, you changed, great. So this is the,
2023.
this is the full 2023 year data. And you can see that overdose deaths in Canada tend to start out west and kind of cascade east, with the lower numbers being in the Maritimes and Quebec, with the highest being in BC, Alberta. But Ontario also has had a rise. And so really from the west, we're seeing increasing numbers. The Q4 of 2024 data that we do have is quite similar. We haven't seen a huge amount of change, which is good, but still a significant amount of morbidity. Nova Scotia itself, so in 2023, had 73 overdose deaths, Q1 and Q4 of 2023, and so Q4 of 2023 and Q1 of 2024 saw quite a significant rise for us, kind of an exponential uptick, all of which were driven by fentanyl. So, it's concerning given what's happening out west, seeing that trend here. We're still waiting on the rest of 2024 data, but we don't have that graph, but I wanted to at least mention it. So to also provide scope as to how significant this is. So since 2016, we've had 47,000 deaths. That's kind of on par with what COVID-19 has done to our country. And so it's pretty significant, and we've seen the huge public health interventions that we put in place for COVID, and we really haven't responded in the same way for the opioid crisis. So right now we've got 21 deaths a day in Canada, and in 2023, 8,480. And like I mentioned before, a slight decrease in Q1 of 24, but not significant. And so what's causing these deaths? Really, the answer is pretty short and sweet. It's fentanyl. Here you can see, the types of opioids present on tox screens in Ontario over the last decade or so, and the big upswing number there, the big upswing tick is fentanyl. Down below, all those other colors are prescribed opioids. So prescriptions are not driving this overdose crisis. It's clearly fentanyl. You can see the little green uptick there in 2019. That's carfentanil, which is another highly potent synthetic opioid. And furthermore, we've seen over this period with our overdose crisis, the prescriptions of opioids by prescribers have decreased, both high dose and low dose. So any theory that these deaths are caused by prescriptions really just isn't true based on the numbers that we're seeing. We're seeing less prescriptions over the last half decade and more deaths, all confirmed to be from synthetic opioids that are causing this issue. So it's, like I said, quite clear that unregulated and illicit fentanyl has dramatically changed the status quo. This has changed how we need to approach this issue, and it's changed our numbers, certainly for the worse. Just want to touch on a couple pieces about the drug supply further. So this is some drug testing from London, Ontario, and it just shows the variability in some of these tests. So one sample had 77% concentration of fentanyl. Other samples had 16%. Others didn't have any at all, just mostly meth. So the user is not knowing what they're purchasing, and it's really quite dangerous. Not to mention how potent these components are, right? So we demand, when we consume alcohol, that we know a 5% can of beer, we know what the effect is going to be. Could you imagine going home after work and drinking a beer and not knowing if it was 5% or 90%? That would be an unacceptable standard for us. But unfortunately, that's what people who use opioids and other illicit drugs are facing. Additionally, within the same sample, if you take a piece from one end and a piece from the other end, you're seeing a difference in percentage. So even if you buy a sample and test it, you could take another piece from that same sample and have a completely different effect. Highly, highly dangerous. And the last thing I'll say is there's contaminants in all of these too. So it's not just fentanyl concentrations. We're also dealing with other sedatives and other things that lower your respiratory rate and increase your chance of death. So just to highlight how much danger there is in this and what's actually driving us. And so when we look at how do we manage opioid use disorder, well, traditionally, we've done lots of different things, but we're finding that those interventions may not actually cut the butter, cut the mustard. What's the saying? Cut the mustard. And so we often think of, drug rehab and drug detox. Well, in fact, for opioids, it's highly dangerous. When we study the outcomes from it, we actually see increased deaths from people who attend detox or rehab. So what I mean by that is abstinence-based treatment where people aren't started on medications or started on pharmacotherapy for opioid use disorder. And when we compare things like methadone and buprenorphine, which are kind of gold standard treatments that exist widely in Canada, those decrease our risks of death, 48% and 44%. Non-medication residential treatments increases the chance of death in this study by 77%. So pretty significant. The other problem with methadone and buprenorphine is it notoriously has kind of poor retention. It's a type of treatment that often doesn't fit people's lifestyles, doesn't meet people's needs, and so the treatment works, but people have to stick with it. And a lot of the times people can't stick with treatment for more than, say, 100 days or so, which creates a void. You know, how do we manage people who the main treatments aren't working for? The drug supply is so toxic, we need to find a way to kind of solve that issue. Not to mention that 1/3 of all of these opioid overdose deaths aren't from people who meet the criteria for substance use disorder or opioid use disorder, people who wouldn't qualify for treatment to begin with. So lots of issues to think about. And in our approach to treatment, these are some of them. So like I mentioned, methadone and Suboxone, that's opioid agonist treatment, widely available, super evidence-based, previously was quite stigmatized decades ago, or even less, a decade ago, and still carries some stigma, but is not going to meet the needs for everybody, and certainly not going to meet the needs for people who don't meet the criteria for severe opioid use disorder. And then moving on to other responses, so we've got supervised injectable opioid agonist treatments called IOUT, or heroin-assisted treatment. So that's a medicalized model, and I think Matt's going to go into more models later, so I'm not going to get into too much depth, but those are medicalized models where injections are provided in the witnessing of those doses by healthcare professionals. Of course, we've prescribed safer supply programs, which we're going to talk about in depth tonight, and other harm reduction interventions like take-home naloxone distribution and supervised consumption sites. And I'm going to hand it over to Matt.
Thanks, Mike. And I don't know if it's easy to tell, but I am the drug user of our panel, and I may be a little bit rough around the edges, but I've done a lot of this work for many different years with all these great healthcare providers and advocates. And yeah, so when I first got into this work, I was working for the Canadian Association of People Who Use Drugs. And this whole term on safe or safer supply really concepted from our work with the Canadian Association of People Who Use Drugs. So when we talk about safe supply, what does that mean? So safe supply refers to a legal and regulated supply of drugs with mind body altering properties that have only been accessible through the illicit drug market. So drugs like opioids, such as heroin, stimulants such as cocaine and crystal meth, and even things like hallucinogens such as MDMA and LSD. So without all the advocacy work us people who use drugs done to create the safe supply concept document, I don't think we'd be talking about safer supply today, because it's very similar, but like safer supply is more a medical approach, and we need them both. So the three models of safe supply I'm going to talk about today are heroin-assisted treatment, medical safe supply, and compassion clubs. And you can see that I put the arrow in between because heroin-assisted treatment is very similar to medical safe supply, and compassion clubs have this, they're not as closely aligned with medical safe supply, but there's a form of market regulation with compassion clubs. I have personal experience with accessing medical safe supply, which I'll speak to a little bit later, but I also got personal experience with accessing the compassion club out of Vancouver, and it's been a wonderful experience. And at the end of the day, these models of safe supply kept me alive to continue to do this work. So here's kind of like this drug policy spectrum, and on your left axis you see social and health harms, and then on your right axis, bottom axis, you see these different approaches to look at kind of prohibition, decriminalization, harm reduction, light market regulation, and unrestricted access. And when you look at the U-shaped kind of thing in the middle, if you're with the unregulated criminal market, it's very high on your left axis, and it's very high on your right axis. So we really need to find this approach in the middle that has kind of some strict regulation and control. It doesn't have to be, I don't know if it needs to be really strict, but it needs to be comprehensively tested to allow people to know what they are receiving. So this was adapted from Dr. John Marks, who was really the pioneer in heroin-assisted treatment. But I always like to say, like, with heroin-assisted treatment, medical safe supply, and compassion clubs, they all kind of fall into this middle access where it's like the harms are low, there is some regulation and some control, and I feel like that's the best approach to keep people safe with a variety of different models. And I'm going to talk about those models next. So the first heroin-assisted treatment program came from Dr. John Marks, who was out of London.
I think up north, like
Liverpool, but the UK, right?
Yeah.
So, he essentially wanted to provide heroin and even things like cocaine to his patients. Now, heroin-assisted treatment is operated in a variety amount of countries around the world, including the Netherlands, the United Kingdom, Switzerland, Canada, and Germany. And I must say, if you do any kind of academic literature, if you just want to look at some of the peer-reviewed literature on heroin-assisted treatment, it's very robust, it's extensive, and there's a lot of it. And I must say it is a very medical approach for people, but it works for the target population. So, for example, in Canada, our heroin-assisted treatment program operates out of the Crosstown Clinic, and it's operating out of Vancouver's downtown east side. They have approximately 120 plus patients, maybe some more now. This was from a couple years ago. But they get prescribed liquid diacetylmorphine or liquid hydromorphone, and it's supervised consumption by a nurse. So, they go to the clinic up to 3 times a day for a short period of time. I think they have up to like 7 minutes to inject their dose. And it's interesting because a lot of people just tend to muscle their dose, right? And, for a lot of people who use drugs, they want to get that IV dose. So, I think it's important to look at other approaches. If people are continuously missing their doses, we should be looking at things like fentanyl patches or other ways to keep them comfortable. This is a picture I took when I went out to Crosstown Clinic, and I was surprised. Like, I was, very young in this work. I was probably still using a little bit, but they let me go and spend a whole day there and talk to the clients, talk to the healthcare providers, do the rounds. And it taught me a lot about Crosstown Clinic. And, there's a limit of how much diacetylmorphine we can bring into the country, so we can't really ramp these up too robustly, but I do know that the Dr. Peter AIDS Foundation has about 20 patients on diacetylmorphine, and there are some, social enterprise models looking at trying to bring more diacetylmorphine into the country legally. So medical safe supply, and I do have experience with medical safe supply. I was on an interesting combination of drugs. I was on hydromorphone, fentanyl, a fentanyl patch, benzodiazepines, and Ritalin. But at that time, before I got into the safe supply program, I was using close to 2 to 3 grams of fentanyl a day. I was using close to 2 to 3 grams of cocaine a day. I was using Xanax. So I needed an alternative to keep me alive. And, you know, like, I'm so grateful that I had great doctors and great support to kind of get me into the program and allow me to, you know, stay alive during a very chaotic time of my substance use. So the most common medications for medical safe supply, or, you know, safer supply, are hydromorphone, Dilaudid, diacetylmorphone, slow release oral morphine. But there are many various programs that offer powdered fentanyl, sufentanil, furofentanil, and fentanyl patches. Fentanyl patches are working very well in Vancouver's downtown east side. They have a little bit of issues with the transdermal patch sticking on their skin, but the Vancouver area network of drug using people just went and bought a bunch of hockey tape and just taped them on their arms. So, you know, like, we're pretty creative when we want to, or if it's going to affect our drugs, to find something that works. But there's also prescription stimulants, so Ritalin, Adderall, Dextrogen, and I know, like, you know, it's hard to kind of find a perfect prescription alternative stimulant for something like cocaine or crack cocaine, but with the medications that we do have, I found them to be effective. I'm on Vyvanse now, and I don't have half as many cravings for stimulants. They're prescribed by a physician, and you pick them up at a clinic or a pharmacy. And they're hard to receive take-home doses. So there are certainly limitations to these programs, but they, you know, like I said many times, they kept me alive, and I'm very grateful for having that opportunity. So I'm just going to talk a little bit about what's going on in Vancouver. And they do all kinds of things. They have, like, powdered fentanyl programs. They have injectable fentanyl programs. They have the fentanyl patch programs. So they've been very innovative with their approach. And I think what's unique about Atlantic Canada, you know, we never really had diacetylmorphine. Yes, we do have fentanyl here nowadays, but I would still argue that the most unregulated drug that people are mainly diverted, or, you know, just hydromorph that people get either from safe supply or get from, you know, maybe a partner because they're sick. And, you know, there's all kinds of reasons why people may share their meds to keep their partner from being sick. So I think that's important to note, and I think, you know, we have a really interesting opportunity to collect a lot of data around what's working in Atlantic Canada and use that for advocacy. So this was published in the CMAJ from Dr. Christy Silverman, who's a fellow Nova Scotian. And, you know, they did these case studies, how a powdered fentanyl program has improved the quality of life. They said, I have much more structure. There isn't much reliability in trying to survive off of street dope, and you never know what they put in it. And it was actually picked up in the New York Times, which I always find is interesting. So compassion clubs, what do we talk about when we're talking about compassion clubs? You know, so a compassion club is a place where people pool together their money to buy safe drugs for cheaper, usually through the dark web. But once they get those drugs, the drugs are some of the most comprehensively tested drugs out there. So, you know, they get them off the dark web, they test them, and then for a while they were giving them out for free, but then once they started to operate the Compassion Club, they would, you know, if I went to Vancouver, which I do quite often, they would give me a code, I'd go to a store and I'd buy cocaine with my debit card, right? So, like, I feel like it's a very interesting approach to, and they call it a market regulation initiative. So they're not saying it's completely legalization, but they are saying it's, you know, it's some form of regulation. And the most important thing is that when people know their quality and quantity of what they're using, it reduces overdose. So, you know, I think that's very important to note. So
the group out of Vancouver is the Drug User Liberation Front. And, you know, unfortunately, they did get arrested and charged with trafficking. But my supervisor in my research right now, he actually funded the Compassion Club. He put it through 2 REB ethics boards. Vancouver Coastal Health was going to give him $200,000, and some journalist or whatnot or some politician got wind of that, and that kind of put the kibosh to the whole thing, which led to the arrests. I know my supervisor, he had a lawyer on retainer because he thought he might have got arrested. But you know what, they've done amazing work, and you know what, I feel like it's going to be very hard for the judge to look at all the evidence and not agree with their approach. So to be a member of the Compassion Club, you have to be 19. You have to be a member of VANDU, which is the Vancouver Area Network of Drug Users. You have to be accessing the illegal and unregulated drug supply of one of the following: heroin, methamphetamine, or cocaine. You must be at high risk of overdose, participating in prevention and naloxone training, and you know, with harm reduction supplies and whatnot, and then agree to participate in baseline 3-month and 6-month evaluation surveys, receive harm reduction education and/or education material, and participate in weekly meetings with programs of staff and peers. So they really crossed all their T's and dotted all their I's before going down that illegal approach. But I have faith that they're going through a constitutional challenge right now, and their criminal court case actually got backed up about a year and a half. So I believe whatever's going to happen in the constitutional case is what's going to happen in the criminal case. But what did they do? So essentially they bought heroin, meth, and cocaine off the drug market, but they just didn't buy it and just give it out. They tested it. They labeled it. Like, this is just like if you were going to the weed store or kind of the vape store or any kind of like the cigarette store, like they tell you what's in it, right? So they use that same approach. You know, they got heroin, diacetylmorphine, 40% caffeine, 60%. You know, keep away from children and pets. You know, this product contains heroin, which is a highly addictive substance. So they were very strategic with their approach, because they didn't just want to seem like they were giving out stuff without, you know, just in a bag, right? And they actually made some really cool hoodies, and they've been fundraising for their legal challenge. But I know when I went and accessed it, you know, I just went and called them. I would go and I'd buy drugs with my debit card. They would let me use them on site. And it was a very cool initiative, and it's sad that it got shut down. But on top of that, you know, they went through all these ethics boards. You know, Vancouver Coastal Health was supposed to give them money, but they still managed to publish 2 academic papers in the International Journal of Drug Policy. They surveyed 47 participants every 3 months, doing like a longitude methodology. They assessed whether they were currently participating or not. And participation in the Compassion Club was associated with 50% reduced likelihood of non-fatal overdose, 60% reduced likelihood of non-fatal overdose involving naloxone administration, which I think is just fantastic. And I think we'll see probably more qualitative data coming from the Drug User Liberation Front. And am I talking about this one then passing it over? Okay. So yeah, this Vancouver Compassion Club was saving lives, then things got political, and that's exactly what happens, right? And you know, I think it's important to when you're, you know, arguing or when you're debating with people on political matters related to safer supply, that, you know, we back it up in evidence. And I know that not all policy change gets changed based on evidence, but I feel like that's a way that we have to continue to move forward and try to get these changes backed in evidence. I know there's a lot of fear mongering and just a lot of misunderstanding from people, and I'm really looking forward to the questions later. But I think just the courage and the amazing work these two did out of Vancouver's downtown east side. They were published in Time magazine for doing really cool work, and I think it's going to be hard for a judge to ignore all the evidence that they collected, and I'm really optimistic that the case is going to get thrown out. And I'll pass it on to Leah.
Right. Okay, so Matt already did a good job of explaining what the safer supply programs look like across Canada, but I can speak to my experience. Like I said, I worked in downtown Ottawa in one of the Health Canada pilots during I guess right after the COVID pandemic. And so what we did, it was mainly people with that are using opioids, specifically fentanyl or carfentanil. And the people that we look at to get into this harm reduction approach type of care are people that are on the brink of death, right? They're overdosing 2 to 3 times a week, Every day they're just trying to get medication from the street so that they are not sick any longer. And they never know what's in their supply, like Mike was discussing. So these people are in need of an approach that we can't provide, we haven't been able to provide with normal opioid agonist therapy. So a lot of the people that I saw had been on Suboxone, had been on methadone, had been on Cadian, which are all 3 types of opioid agonist therapy, which is the treatment for opioid use disorder, and had little to no improvement in their well-being. And so they would come and they're asking for safer supply. So what is that? We prescribed Dilaudid, so it would be a daily dispensed prescription. You'd have to go to the pharmacy every day, and you'd get a certain amount of Dilaudid 8 milligram tabs. And then they can take them home and use them as they please. So some people would just take them by mouth, but other people would inject them in a safer way. And that way, at least they knew what was in the pharmaceutical grade medication that we're giving them. Some people did want to have a backbone, such as methadone, Cadian, or even Suboxone. And as Matt talked about, the fentanyl patches, that's an option as well. And some people didn't. But, I saw people who would start just on safer supply, and then, their overdoses would decrease, the amount of fentanyl they were using per week would decrease until nothing, and then they would change where they're going next. So they say, hey, now I want to try methadone again, or now I want to decrease my safer supplies prescription and increase my methadone. I'm in a different stage of life. So opioids are commonly what we refer to as safer supply, but we also do prescription stimulants, as Matt was discussing. It's really hard, again, to say exactly what the prescription should be for the street supply, again, because it's toxic and unregulated. But we would prescribe usually starting at ADHD dosing for people, but going up depending on the response. So over COVID, there was a scale up of the safer supply programs across Canada. So as we were saying, and as we saw the data at the start, the crisis is kind of going west to east. So more was happening out west and slowly coming over to the East Coast. There was a 258% increase in sites offering safer supply in 2020, which is phenomenal. However, just to kind of put that into more context, in BC, there's 225,000 people that were using unregulated drugs. About 4,000 people out of that had access to safer supply, and that's less than 2%. So obviously there was a big uptick, but there's still room for us to go. And so just as we see that we're having an increase in the amount of safer supply that's available to people in Canada, we're also having an increase in evidence base. And so here, there's a scoping review that was done in 2024, was it? Yeah. And there was 17 peer-reviewed journals, and then also 7 program evaluations that were looked at. Both quantitative and qualitative data were looked at. And in general, there was a decrease or no change in toxic events that happened out of these program reviews. Also, there was a decrease in unregulated opioid use as well. What we also saw is that there's an increase in access to healthcare. So, like I said, when people are coming into your clinic every week, we can also get some wraparound support for folks. So whether that be psychiatry or social work, just having someone come into care that often is helpful, and I've seen that firsthand. Also, decreased infectious complications. Again, when I would see clients coming into my clinic, often I could give them a prescription by mouth to help with some of the infections that are related to IV drug use, and that would keep them out of the hospital, and subsequently impact their quality of life and improve their mental health. And what this scoping review also showed was that there was a decreased engagement in criminal activity. Also, and so in 2024, there was a BMJ study that was looking at the risk mitigation guidance that most of us followed during COVID. There was a guideline that was published. And so it's for opioid and stimulant dispensations on mortality and acute care visits during the dual public health emergencies, so the opioid crisis as well as the COVID-19 crisis. And what they saw was that even one day of safer supply decreased the mortality risk for 61% of people the next week. So that's a huge decrease. It also showed that just one day of safer supply per week, there was a 55% lower rate of death from overdose the next week, which is, again, wild. 4 days of safer supply would result in a 91% decrease of mortality in the following week. So I think those numbers they speak for themselves. And so looking into the qualitative research, so there's multiple studies that have been done, and I'm not going to get into the nitty-gritty. I think that a lot of this is going to be a good conversation, but I can speak to my experience, like I said. From the qualitative research, what I've seen is that, again, there's fewer overdoses. Again, there's decreased frequency of use of illicit drugs. So I would watch people's urine drug screens come back week by week, and it would be less and less frequent that they would have fentanyl in their system. And people also would like to see what's in their system through the urine drug test, because no idea what you're getting from the street. You would also see a reduction of cravings and withdrawal due to the access of pharmaceuticals. When people are in this chaotic use, like every day is like hunting and struggle and trying to get out of this sickness. And so taking away some of that is obviously really helpful for their general well-being. So this increased stability in the patterns of the drug use that they saw, and also better health status and increased stability in their lives. So I've had a lot of clients that, started by living on the street, and one of the best kind of anecdotes from my time prescribing safer supply is somebody who was homeless, then who got housed, and then was working and no longer using fentanyl after. And so obviously it's not perfect, and we're going to discuss back and forth hopefully today about that. So our programs, we're typically giving hydromorphone. We need different medication options, and also we're combating such a high tolerance in people that often we can't get to where we need to with the prescriptions that we have. And that's the next point. So insufficient doses, and then also the program capacity. So I'm sure that Leah will talk about that now. Like, there's such a wait list to get onto the MOSH program. And so in thinking about equity and also just, especially equity, it's always in the urban centers that you have these safer supply programs. So lots of people in rural places aren't able to access So that's something that we can work on. Oh, and that's it. I spent through.
All right. A little acrobatics. I forgot you're not doing a piece. Just ending with me. How are we feeling? Oh, you do? Okay, good, of course. It's got a few in the background. Okay, so we're going to get into kind of, I think, some of the deeper discussion. I'll kind of round out some of the chat here. And I think these are probably the pieces that we're going to be talking a lot about. Can you hear me? Because I'm like a low talker. There we go. And I'm also short. There, that's better. I know, I'm not very good at that. So look, people have concerns about safe supply, and we acknowledge that. It's a hard thing for a lot of people to wrap their minds around because it's a bit of a shift for how our society has talked about substance use and kind of, helped, kind of frame the conversation. And I think that the really unfortunate thing in our country is that that conversation is really becoming quite polarized. When in fact, a lot of the things that people worry about in safer supply programs are the things that we also worry about, and the things that keep, whoever the people in the room who are like, I'm not sure what this is all about. I've probably had some sleepless nights myself about that, just in terms of thinking these things through. Because of course, in an ideal world, there would be a regulated drug supply, and we'd have a model like Matt described, where if you want to have a substance, you can go into a store and get a regulated substance and use it, and not have to worry about people like me, kind of being gatekeepers, which feels really uncomfortable. And I think we're also conscious too, that in our unique environment in Atlantic Canada, where we've largely been protected from the overdose crisis for a long time, because our opioid supply has largely been pharmaceutical. And so that's been protective for us, and now we're seeing these changes. And so, in a small pond, when we're introducing safe supply prescriptions, we're also thinking about like, how does that impact downstream market and, public health and all these things. And also, we're the only, I'm like, I'm too close, I'm like too loud, I'm not loud enough, I'm all the things. Where we're the only tablet safe supply program in Atlantic Canada, we're also needing to like fiercely protect that and the people that are benefiting from it. And so the people who are kind of throwing tomatoes and, wanting us to not be in existence, we have to be really mindful about that too, and kind of keep things, really tight. And so it's a challenge. And Tommy was at our Safe Supply Clinic today and just saw some of, the weight of some of those things that we carry and that we think very deeply about. So we're going to go through some of the things. So these are some of the things that come up. Mainly the National Post, but in lots of other places. But, safe supply causing things like increased mortality. We're killing people with safe supply. It's being diverted. We're flooding the streets with dilaudidates. It's impacting our youth. And now no one's going to choose OAT because now there's like all this safe supply, which is just frankly not true, but we're going to go through it. And so I will say, and I said this in the last thing we did, which at the time landed pretty well, but it didn't really mean to come out, but what I want to express is that these are things that we think a lot about. We're very careful and thoughtful about who we're prescribing safe supply to. And so I made the comment, and it was actually the first time I said it, that we're not, I know Mike's like, oh my God, here she goes, but we're not willy-nilly dilly dealers. And I gotta make a shirt about that. Because we're not, because we think about it. Maybe we should be, but we're not. And so that's the last time I'll bring that up publicly, but Tommy's going to make me a shirt that says that. Okay, so we're not killing people with safe supply. Spoiler. This is data from BC and Ontario. I'm looking at, can you guys read that? It's like really small. I don't have a pointer thingy, but let's just do this. So the top line is fentanyl. All this to say is like, fentanyl is driving the overdose crisis, period. That's the end of the conversation. But we are looking at the data to make sure that we're not seeing signals that safe supply is impacting that. So
blue is pre-pandemic, yellow is kind of post-pandemic data, and you can see sort of like fentanyl, methadone, hydromorphone. So the rates of death have actually decreased in the hydromorphone group, and really the places where you're seeing it increase is fentanyl. Ontario looking similarly, that actually the death rates, so the death rates in Ontario are dropping from pharmaceutical opioids, and the BC coroner is also saying that there was no signal at all that the safe opioid supply there is contributing to opioid deaths. Oh, there we go. That's what I'm looking for. So here we go. If you don't believe me, believe the Toronto Star, that this notion of all the widespread diversion of BC safe supply is just, it's not what's killing people. And actually, you know, if you think about it, we've been protected here because our drug supply has been pharmaceutical. And so a few extra dilated dates around is probably not a bad thing from a public health perspective. If we're just thinking objectively about things without take away our fear, take away kind of like the emotional reaction to that, and just and think about that. So in any event, what are we doing to the kids? Safe supply is not really having an impact in youth. It is not having an impact in youth. Sadly, there were trends in increased opioid toxicity deaths among youth in Ontario during the COVID pandemic, and so that's where this data comes from here. But those deaths, again, were driven by fentanyl. If you look at sort of the bottom bars, are there little chummies that come up there? No, they're not. Okay. So this one on the far right, so you can see, if you go to the very bottom, everybody down. It's nothing to be alarmed about. So pharmaceutical... These ones, so you're seeing like the pharmaceutical supply or drugs on the left. You know, we're seeing like decreases in the overdose rates, and then fentanyl. It's all going up. So this is not this is not driving the overdose deaths in youth. And the other important factor to note from the Ontario data in the tragedy of the deaths among youth is that it's more often associated with other substances, particularly benzodiazepines. And this is looking at, so this is data from, oh, did you take out that slide? Oh, you scallywag, look at, do you start here?
You can have that one if you want.
No, that's okay. I don't want to talk about Anzivo. I'll give that to you. There was okay, so anyway, so the Provincial Officer of Health in BC also looked at rates of opioid use. So we can say that, okay, we know that safe supply is not driving opioid toxicity deaths in youth, but are more young people being exposed to opioids because there's all these dilaudid floating around? The answer is no. And so this is data from BC. So the top light blue line is for ages sort of 19 to 24, and yet you can actually see that there's like a decrease in opioid use disorder, and the bottom dark blue line is people age under 19, and that's really staying static. So we're not increasing the rates of opioid use disorder. The kids are not dying of at an increased rates because of opioid safe supply. I used to work in the downtown east side before I found my life in medicine, and you know, when I worked there, people would come to the downtown east side then to buy tablets too, and so that's always been a thing. It's just now it's kind of being sensationalized and saying that's all coming from safe supply. Am I done now, or okay? Because what about the other pieces about safe supply at the end?
Which ones?
Tommy edited our slides last night and didn't tell us. No, you did, but I probably didn't read that email. I guess just the piece to say quickly is that, and maybe this is stealing your thunder, so just kick me if I am, but so safe supply it's very helpful. Oh, we didn't talk about the big D and little d diversion. Did you take that slide out?
Probably, yeah.
Okay.
Go for it, though.
Can I talk about it now?
Yeah.
Okay. We're going to talk about diversion because it's almost 8 o'clock.
Go for it.
Okay.
Yeah.
Because I think we have to talk about it, okay? Because it's in the media and everybody's panicked about it, and there's reason to be worried. And as I say, these are things that keep us, up at night too. But the word diversion is thrown around a lot, and when we talk about it, we talk about capital D diversion and little d diversion. Capital D diversion is I'm giving somebody a prescription, they're not taking any of it, and it's all being sold. And, you know, we have a lot of people, we have 95 people on our 50-person pilot for opioid safe supply. We have 105 people on our wait list, and that's growing. So we don't have room in our program for people who aren't taking any of their safe supply. The other capital D diversion is maybe somebody's selling all of their safe supply to sort of continue to purchase fentanyl. Now, I recognize that there are some benefits from them in not having to engage in other criminal things, and it may be protecting their safety, but when that starts to impact the safety of others and there's violence and stuff and other things, that transactions that are happening, that's also kind of capital D diversion. Little d diversion is kind of the stuff that Matt was talking about, helping out a friend who is in withdrawal, or, is trying not to engage in survival sex work, or engage in criminal activities or whatever. It's called compassion, and it's called taking care of one another, and we understand that happens, and we're glad that it does. And so, if we have clients on our program where that's happening, we have a conversation and we talk about it, but little d diversion is probably, impacting a lot of our overdose deaths, and so we have to have a little bit of leeway for that. And then the final piece I'll say, and then I'll stop talking, is that, and we're probably going to get into this more deeply in the conversation, but, I think that safe supply is, it's important. It's not a panacea. Especially coming from somebody like me, a doctor that you have to go to an office to, and then you got to go to, it's layered and like medical stuff, and it can be really great, and it can absolutely change how people engage in care and the trust they feel in care, and it can be really beautiful and wonderful, but it doesn't tick all the boxes. There's a really limited availability of what's on the menu for what we can offer. If people want to inhale their drugs, I don't have things for that, So it's really limited in scope. It really doesn't serve everyone. It serves some people really well, and it's medicalized. I think that's all I will say for now. Just that I think that we have to be part of the if we're going to be against kind of medicalized safe supply, then we must also lean into the conversations of, okay, but then what is that regulation, or what are we all going to come together to fight for? Is that decrim? Is that regulation, or what is that? Because safe supply is helpful, but it's not the whole answer, and we need to do better for the people we care about. That's it. Thanks.
I'm just going to finish up our initial presentation here, talking about some of the political blowback, backlash against harm reduction generally that's been happening over the past year. As we talked about, safe supply is a relatively new intervention. It's expanded. It's been pretty radical since the start of COVID, but still happening on quite a small scale. And unfortunately, it's been the edge of the wedge for this kind of political blowback, political talking points, unsubstantiated rumors, op-eds, commentators publishing these big articles, part of an organized, well-funded conservative movement, unfortunately, with similar language, similar terminology. It's now encompassing all of harm reduction, Poilievre's drug dens, and happening in BC, and it's already leading to real harm. So Ontario closing 10 of 17 of their supervised consumption sites in the province, and the BC Conservatives in their election vowing to shut these things down. Politically convenient, dehumanizing, and has been, unfortunately, I think, politically successful, even though it's completely separated from the evidence and the public health policy that we've been talking about. And so Leah brought up the question of what's the alternative, and part of this movement has been asking this question publicly, trying to normalize this idea of involuntary treatment. This was last year in New Brunswick. Public Safety Minister Chris Austin saying, what we're doing is not effective, keeping people on the streets. We're getting overdoses on the streets regularly, so simply turning a blind eye to these issues, throwing up our hands is not the answer. As if that's the only alternative to public suffering and poverty and homelessness is going to be involuntary treatment, that it has to be one or the other. This really false framing. And Debbie Warren, who's Executive Director of Ensemble Moncton, the harm reduction organization in Moncton, calling this out in the article, says, someone goes to detox only to discharge them into homelessness. They go to hospital for heart valve replacements resulting from substance use, only to be gone into homelessness again. If the government wants to address drug addiction effectively, it should create more housing, help people get back on their feet, reduce the stresses that push them to use substances in the first place. So she's pointing to these social forces that lead to public drug use and public suffering that harm reduction interventions are trying to help in a small way, but can't overcome all these political and economic issues. And this idea of blaming an addiction and blaming an individual who then needs individual addiction treatment or to be removed from public life is not a new political issue, and has come up again and again and again. This study here just screenshotted links this to in the 1980s, similar issues with homelessness and poverty in New York City. The government had an organized campaign to link this to mental illness and saying that the treatment for this medical problem is medical treatment to justify removing homeless people from public spaces. And we're seeing it again. So this conversation has come up about involuntary treatment in Canada, perhaps as an alternative to things like safer supply to try to solve our overdose crisis and thousands of deaths a year. And there have been places in the world where involuntary treatment's been tried. This was published this year at International Journal of Drug Policy. People who in Iran who, if they didn't abstain and complete their year of treatment, they would go to prison, and followed up their actual outcomes, and less than 3% were abstinent at 12 months follow-up. So this, what's pitched as the alternative, involuntary treatment, get people off the streets and couched in the language of compassion, doesn't actually help, and as Mike showed that study earlier, increases people's risk of dying. So won't be a solution to our overdose crisis, unfortunately, but so we're trying to push back against that narrative a little bit. And that's it for our slides. So happy to open things up or hand it back to you, Sheila. Whatever you want to do.
What I'd like to do is just open it up to folks in the room. Just you looking around, I know that a lot of people are bringing experience and you have questions, or even if you have something that you feel hasn't been covered in the presentation and you'd like to kind of put it on the table as something live for us to consider. I'm just going to pause. Yeah, go ahead, please.
Hi, thank you all again. 2 questions. First one's these one. Can I get a copy of your slides? The next question is, obviously the politics is the barrier, and that's concerning with the conservative governments. But if you took them away, which is not an easy feat, what would you really like to do, or what would be, if you had resources and political support, what could you do that you're not doing now? Would it just be more providers, you have a wait list, or something different, or?
I think the answer is just like, even if the conservatives get in federally and they want to defund all these safe supply programs, like from my experience accessing it, if you can find a good doctor that you can connect with and build a relationship with, like pure poly-ed doesn't have any control over a doctor and their patient's relationship, right? So I think there are ways to still kind of provide, de facto safe supply. It wouldn't be as robust, you wouldn't have wraparound care, it wouldn't be a lot harder to scale up, but I think, there's people that we really can't, just let go once they try to shut everything down. And I think, there's a lot of great doctors on this panel that, I think will probably continue to support people regardless of what the political climate is.
One thing I want to add to Matt's point is, federally, it's hard to control what physicians can do. However, in Alberta, there has been legislature placed that makes safe supply illegal, which I was like, oh, it's okay, I'll go to jail for it. But it's actually a $50,000 fine, or is it $10,000?
It's $10,000 per patient per day to the pharmacist and the prescriber.
Mm-hmm.
Yeah.
So it's pretty significant. So there is ways that government can place control over even the sacred patient-doctor relationship, which is like quite terrifying. People don't tell me which medications I can use to treat diabetes, yet they're trying to define how I can best manage an individual's healthcare. But to answer your question about what would I want, and the answer really is actually more of everything, because no one intervention is going to fit for everybody. Some people will be very happy with medical safe supply, and that's an easy one for us because all you need is a physician, some funding for those hours, and a pharmacy, and medication coverage. But there's just so many variabilities. High opioid tolerance means that we can't meet that need with tablets. Some people would prefer to continue to use substances that they can procure, but they want to use it in a safe place. So we need more safe consumption sites. You know, so we really just need an overall investment in all of the evidence-based harm reduction policies that we have. And if we could do that, that would make a big difference.
Is this happening in medical school, or in medical still the hidden curriculum still influencing prescribing patterns?
It's hidden curriculum.
I think yes.
What I mean by
I
hidden
don't think it-
curriculum is the people who have got hardcore pass on their values and prescribing patterns to students, and it's often anti-drugs or antidepressants and stuff. So I wonder, I mean, I've been out for years, if the hidden curriculum is still as strong as ever.
I can say that I've given a couple talks at the medical school. None of them have been actually part of the curriculum. All of them have been interest groups and students who are interested, and me going to their lounge, speaking behind closed doors about this kind of rogue medicine.
Yeah,
That
so,
speaks for itself.
yeah, I mean, so I do I think a harm reduction, I don't know what the talk is, oh God, my voice. Okay, so the answer is actually that yes, it's still like the, you know, no opioid prescribing, all that kind of stuff, but and like safe opioid prescribing, I guess, is how it's kind of packaged. I do one harm reduction talk, and we have embedded some cases for learners. However, so we don't have a regular addiction medicine curriculum. We don't have a place. We don't have a department of addiction medicine in the medical school here, which there are in other places. It's kind of like a haphazard thing in the Department of Psychiatry. Like I used to take psychiatry residents every year, and it was like these little 1 month of exposure. So we don't have anybody that we're actively purposely training for concurrent or co-occurring disorders of mental health and substance use. So it's all still very stigmatizing. The other thing I will say though is that, and this is I guess for the people who may be part of the university in the room, it's just that also all the people who are doing this teaching don't get paid for any of it. So everything is which is fine, except that it also doesn't really, you don't have the people who are doing this work as preceptors in the medical school. You know, even I'm trying to assemble a panel of people, patients to come and talk to people, and I'm trying to figure out well, I'm not going to bring patients unless don't pay me, fine, but you've got to pay everyone else who's coming. And so, you know, there's this whole, it's just, yet it's not, what that says to me is that that's not important enough to be a part of the curriculum. So that's an issue. And I also just wanted to touch on the piece about the prescriber, because you're quite right, because it was really smart what they did in Alberta, because I think there were lots of enthusiastic prescribers who were yeah, I'll go to jail for this. And they knew that, right? But they didn't want the media story, so instead they wanted to just financially handcuff everybody and you know, make them not able to do it. But there are some prescribers in the country who are absolutely being terrorized by the federal government and having to take prolonged leave and you know, look at kind of legal pieces and all that kind of stuff. And it's destroying their life, their livelihood, their family, because they had the courage to do this really small slice of the big pie that we actually need. So there's part of that here, but we're not going anywhere, Matt. So we'll still be doing it, I hope.
Yeah.
We're not gonna have each other.
And yeah, I'd just like to add on a couple of things, what I would like to see as someone with lived experience of substance use. I've been on and off safe supply, I've been on and off methadone, I've tried every avenue, buprenorphine, methadone, Sublocade, and you know, I think, you know, we really need to provide options for people. You know, we need things like fentanyl powder, fentanyl patches, you know, and I don't think it always has to be just because people are using fentanyl. There's other reasons, right? People may have issues with injection, their age is getting up there, and you know, they just can't find a vein anymore, and you know, they're constantly sick, right? And I think these medications are very well based in evidence. You know, they work really well in Vancouver. I'd love to see things like pharmaceutical cocaine, and you know, because I feel like a lot of the stimulant replacement options we have just it's not the same as cocaine, right? And I feel like that's what the Drug User Liberation Front did very well, where they, you know, they bought cocaine, they bought heroin, they bought methamphetamine, they comprehensively tested it. Like there's probably never been so, like, yeah, just never been drugs tested that well. And I think, you know, it'd be great to have a compassion cocaine club here, and you know, there's all kinds of different options available, and yeah, you know, and just because you're on safe supply for a couple months doesn't mean you, like a lot of times people get on safe supply and they're like, oh, well maybe I want to transition back to methadone. It provides a little bit more stability, right? Like it's, you don't need to just be on one medication and that works. But I think we got to go up and down, you know, maybe they try something a little bit more out of the ordinary, like a fentanyl patch, or maybe they try benzos. And like, I think, you know, like for me, I was on every different drug possible, but I was overdosing every week, you know, like I'm very lucky to still be alive. And if I didn't get the combination of drugs I did from the Safe Supply program, like I know I would not be here. Like I almost died, not from the drugs I was using on the Safe Supply program, but just because I was still seeking unregulated fentanyl. But if I didn't have that tolerance build up from the Safe Supply drugs, then I know I would have died.
Something that I'd like to add is that I've been a patient on Safe Supply, both on and off. And I'm sorry, I'm not sure your name, but you mentioned that most of the patients are on the brink of death. I was 22, 23 years old, you know, almost had been homeless for a good part of my life. And, you know, I transitioned on and off from the Safe Supply program. I take my practice in sobriety. I'm currently abstinent and I'm going to school and I'm doing my best, but I guess I'm just here to say I would not be here today without, you know, some of the people who are up on that stage. I can 100% tell you that.
Thanks for sharing that. I saw Matt had your hand up.
Yeah. Thank you so much, everybody. Really glad to know some of you and meet others. Just one clarification question. I think I know the answer to this, but I think it's really one of the powerful things about events like this is to demystify Safe Supply and make sure we're all sort of on the same page. And then one kind of, I hope, a gentle provocation, but I think it's really important to get to. So on the clarification side, is fentanyl part of Safe Supply or not? Because I think I heard slightly different things there, so I just think it would be helpful to clarify that. And secondly, so completely on board with what you're pushing, but I think what we've seen is advocates, folks with incredible knowledge like yourselves, highlighting this distinction between evidence and politics and how there's this huge gap between the two. But I guess I'd like to push us to think about how we get beyond drawing that distinction and political strategies to try and change that conversation, because frankly, as a person who's been to Vancouver many times, being there 2 weeks ago, it feels different right now. And I think people are operating on the basis of what they see and not what the evidence says, and how people are dying less or they're dying because of some things and not others, like Safe Supply. And yet the political conversation is moving on. So I would invite reflections, love to hear what your thoughts are about how, beyond just sort of saying the evidence doesn't say Safe Supply is the problem, what can we do as a movement, a social movement, a political strategy to try and get politicians, frankly, thinking about this differently? Because I'm afraid that what drives people's decisions is actually an anecdote here or there, or a walk down East Hastings and seeing a problem that was always there but was maybe laid bare now, and all the evidence in the world doesn't matter. So I'd love to hear your thoughts about pushing beyond just drawing that distinction and advocating in a different way.
I can take the fentanyl Safe Supply one to start. So the question was, is fentanyl part of Safe Supply? I think the answer is yes. In in Nova Scotia, it's not part of the regular program because the only formulation available is topical patches. And applying a topical patch doesn't provide any kind of euphoria or maybe a desirable effect that people would be seeking. It is quite helpful when people who are using high doses of opioids need to have that need met. We can put a patch on to at least bring their baseline up so that what we're prescribing that can be used for whatever, euphoria or what have you, or pain or anything, can actually have an effect because we've met their just bare backbone minimum of what they need. In BC, fentanyl is part of safe supply, in Christy Sutherland's program that Matt had mentioned, using some different types of formulations. I think the biggest distinction between safe supply fentanyl and illicit fentanyl is in safe supply fentanyl, we know exactly what it is. We know exactly the concentration. We know exactly how someone's going to respond to that dose, which makes it incredibly safe compared to fentanyl that we refer to, which is, who knows? Yeah, I hope that answers it. Yeah.
Yeah, it's a really good question, Matt. How do we approach this? Sorry, low talking again. God. I think about it a lot because I think that in Atlantic Canada, we're used to being 10 years behind everything and catching up. And we're seeing all these other things happening. And I have a lot of colleagues in Calgary where I used to work who are just just struggling, grieving everything that's happening up there. And I feel like this is really a moment socially where Atlantic Canada can be leaders. Because we really, we rest on our laurels here, right? That we're kind and we care for one another and we care about our communities. And we kind of have to put our money where our mouths are. And, and so thinking about your question about the magic wand, if we're talking about safety and drug use, we have to talk about housing, we have to talk about poverty, we have to talk about inequity, we have to talk about, the inequity across the province, right? Northern Zone and Eastern Zone are suffering right now with overdoses, and they have a fraction of the resources that we have. Mike and I were there, and Tommy a few weeks ago doing a harm reduction workshop, and my God, what incredible people on the ground who are just fighting with very few resources to just do whatever they can. It's incredible. So, I think that, I don't know, because it has to be a social movement, right? We have to actually give a shit, if I'm allowed to say that, but we have to care about one another, which is what we tell everyone we do, but we actually have to do it. And we all do better when we all do better. And so I think that we really have to get ahead of the narrative of, responding to the Adam Zevos of the world and not be on the defensive of this, actually be a bit more proactive to say, this is what it is, this is what it isn't. These are some of the things, and have those kinds of have conversations like this with a really diverse audience of diverse opinions that have a conversation and lean into one another and, do what we do best in Atlantic Canada, which is care for one another. And I think that if we fail to do that, I think we should all be a little disappointed in ourselves.
And I think we have a really interesting opportunity right now with the Safe Supply Program, with the overdose prevention site, to collect a lot of great data that is going to be very beneficial for safer supply programs. And I know there is some of this work going on, but I think there could always be more. And it'd be interesting to maybe bring some of the people in from Vancouver that have a lot of extensive knowledge on it, because they're going through this de-prescribing things when we're trying to more or less ramp up prescribing. And I think it'd be good learning lessons, not just for us but also for them.
Yeah, well, and for us too. The important piece, sorry, but you have to get this before the horse is out of the barn, right? Once somebody's exclusively using fentanyl and their opioid requirements are bananas, doesn't matter how much Dilaudid I can give you, it's not going to cut the mustard. And so we have an opportunity to get this before it really gets out of control. And, the drug market is going to continue to evolve. So today we're talking about fentanyl, in 10 years we're going to be talking about something else. Crystal meth, it's coming for us. It's already in parts of our province. So it's inhaled, it's going to keep evolving. And so we have to just think differently. We can't keep doing this the way we are.
And I think there was a question about like, how do we make changes politically? And I think politicians are driven by voters, and so we need to educate voters. We need to educate Canadians, and that's going to take money, like advertising. We've had, experts in the field speak at Parliament and speak facts, and those facts have been called into question, and political parties smear their life. It's challenging, and evidence, we've been researching safe consumption sites for 30 years, and the studies repeat and repeat and repeat, and we see benefit and benefit and benefit, and they're closing 10 of them. It doesn't, we're not really winning the fight, so we need to, invest in education and have people recognize that these interventions help, but that's not only it. I think, there's a deep unconscious stigma towards people who use drugs, and it's really easy for people to hear one thing that they want to hear and apply stigma, and it's too easy for opposing political figures to use that stigma to drive a vote, and it's super. There's a lot of public education that has to happen.
Yeah, and on that point, I think it's really important to note that, these political decisions are not based on evidence, they're based on opinion and fear. But I think if we get creative with our knowledge translation and our knowledge dissemination approaches, making kind of very unique videos, very heartfelt videos about people on safe supply or people who use supervised consumption sites that save their lives, maybe doing something like an animated project, right? Because Jeff and I did a talk earlier, and people don't read as much either, right? So I think we gotta translate all this knowledge into ways that people can digest it and make an opinion about it themselves, and hopefully advocate for different ways forward.
I think there's a question in the back there.
I'm a recovering junkie, 16 and a half years clean away from injecting. But my question to the panel is, I heard you talk about safe supply and homelessness, but I never heard anything about mental illness, because I have a son that's on the street with mental illness on your program, that sleeps on the sidewalk, outside the drugstore, where he picks up every day. I have to witness that as a father, as somebody in recovery, daily. And if you knew what was going on in my head, there's been many times I thought, what's the use? I must go back myself. But it's only through the grace of God that I haven't picked up myself. But, I have another son that's on a different program in Dartmouth through another doctor, through gabapentin and whatever else it is that they give up. I live with this every day, and it's very hard for somebody in recovery to have to face that every day when his main issue is mental illness that seems to get brushed aside. If you don't deal with the mental illness, it's never going to change. Because when I was the primary decision maker, which apparently they don't have anymore, if he didn't go get his shot, I just have the police pick him up. They take him, give him a shot, and let him go. They don't do that anymore. So when they go to him, he says, I'm okay. They leave him alone. Even though he's been on the street for 3 months without a bath or a shower, he smells bad. And when he comes to me, he thinks I'm an undercover cop. Somebody who's done 40 years in institutions all their life. He must thinks I'm a cop. Like if you only knew what was going on in my head, I just feel like it's that tough. Right? The mental illness has to be addressed.
And I know there's all kinds, a lot of people don't want to diagnose somebody with a concurring mental illness unless they're 3 or 6 months away from using drugs. But I know that's not always the ideal situation. And I feel like there could be ways where you pair those medications with the safe supply just to kind of get them back in it. like, I'm not the one providing safe supply, but, you know, I've been around these programs a long time.
One, I'm really sorry that this is your experience. It's hard to hear because I feel like the system is completely failing you and your son, which is exactly the case. One, just to kind of pull this into safe supply and harm reduction, is particularly with supervised consumption sites, we know that these sites capture a different group of people that are harder to reach, people with more severe mental illness, people who wouldn't present for traditional treatments. My hope is that having more harm reduction initiatives would be able to, you know, find more people like your son and try to at least engage him or her or whoever is able to engage in these programs and hopefully translate that into better outcomes and better treatment. And we do have evidence that shows that these programs capture those harder to reach people. And it sounds like your son is part of the program, and hopefully we can, you know, use that interaction to maybe improve his life and his outcomes.
Yeah. I just wish safe supply was when I was using.
Yeah.
Because when I was using, you couldn't get a syringe from drugstore.
Right. Yeah. Right. Yeah. All harms.
When I went to a federal penitentiary, there was 500 inmates. We used one syringe for the whole institution. And where was it? Up somebody's butt, so it couldn't be found.
But it's an important point with respect to, I think that, you know, in terms of gaps of mental health and addiction in Nova Scotia, it's a real issue. And we at Mosh, Mosh, we see this often, right? Like stories like that, sadly, are not infrequent. So what you were referencing when like a police officer could go and pick him up and get his injection was like a community treatment order. And our community treatment orders here are very difficult to get. And we have lots of patients at Mosh who we see just do a revolving door with the corrections. And so the pendulum has swung to like, you know, really medicalizing people with severe mental illness and like asylums and institutions to like now actually it's like correctional facilities. And so we have some patients and it's terrible, and you literally set the clock. They get released from jail and we try to engage with them
as research participants.
And that's okay. And so they get released from jail, they're living outside, we go to Mosh to see them in the tent or wherever they are, and we literally set the clock because we know that it's a matter of time before they're gonna get picked up again on a charge that's actually related to their mental illness. And when we even try to take somebody to the emergency room and try to get a psychiatric assessment, it is like, I have never been successful in having support to do that, to try to help diagnose. And then the other piece is then having somebody, a psychiatrist in the community, to follow them ongoing is like winning the lottery. I mean, we're very grateful now that we have Dr. Sonera States who comes to Mosh, and we're trying to build what Mike's kind of referring to as like an ACT team, which is our teams that I worked with in Calgary, where, you know, you had more kind of like acute mental health support who could go out and serve folks right in community that, because the people that we're taking care of in the Mobile Outreach Street Health Clinic have like the most severe mental illness and are falling through the cracks of everything. And so the CTOs require like 2 psychiatric assessments that can't include the forensic assessment that they had in jail, right? And so they have to have admissions, and then they have to have admissions to hospital, and then we can't get anybody admitted. And it is, it's a very broken system. I feel you, and listen, it's so tough.
Also, I'm sorry, I don't mean to steal the show, so to speak. I had severe issues with psychosis at one point, and I can only imagine your frustration, but I understand how difficult it is to get treatment. There was a point where I fell about 25, 30 feet, and I cut my arm open because I had run off a cliff thinking someone was chasing me. And I went to the hospital, and they did not numb or anesthetize the area. They just stapled it, and then they sent me back over to the streets. No care. It was only once I jumped a fence, tore out some of the staples, and a nurse saw me, walked me to the hospital, and said, "You do something about this, or I report you to a higher authority." Did they actually finally involuntarily put me into a psychiatric facility? And even there were times when I would discuss my psychiatric symptoms, and they would say you were drug seeking when I was asking for Seroquel. I can only empathize with the the mental health issues that your son is experiencing. Fortunately, Safe Supply helped me to move away from substances that were causing the drug-induced psychosis, and I was able to return to some amount of, making positive decisions in my life. And my heart breaks that that's not happened for you, but I really hope that that does wind up happening for you too. I hope it, with everything in my heart that is what happens for you too.
Can we go? Okay. First of all, just what a beautiful, I mean, it's really painful and hard, but I'm so grateful for the connections that people are drawing here. I want to go back to just two things. One is, so you mentioned that kind of swing between the jails and the institutions, and you mentioned CTOs or community treatment orders and that they're hard to get, but I think it's really important to pull back a bit from that, because part of the reason they would be hard to get is because the services aren't there. We have to have the services in place in community in order to get the CTO. If we had the voluntary services, that's what I would love to, sort of start with, is the foundation of voluntary services available for folks. Yeah.
I mean, we make things pretty easy with MOSH, right? In terms of if people want, we have our nurses will go out and find somebody to give them their injection wherever they are, right? And if people want to have it, we absolutely make every effort for that to happen.
I guess I'm thinking about mental health treatment, mental health and therapeutic, sort of supports.
Yeah, definitely. And that's all. We absolutely need all of those things.
Yeah.
But sometimes people are it's a few layers away. Things are so acute, and that kind of engageable piece, things need to kind of come down to here. Do you understand what I'm saying? You just have to kind of before some of those things can happen. But people need to be holding one another in those moments, right? When things are really chaotic, and trying to create safe spaces for those kinds of discussions and support. So it's tough. And of course, you never want to put somebody in a CTO unless they absolutely have to. It's sort of, that's all necessary. But when you're seeing somebody go in jail, then get out of jail and almost harm somebody or almost harm themselves and then go back in jail and they're just doing this, you're thinking, what are we doing here?
That was the other piece that I just wanted to put on the table, is the situation in jail. Because we have a few people here who have experience of incarceration, whether federal or provincial or here or elsewhere. But my understanding is we're pretty much the worst in the country in terms of failing people when they are in jail and setting them up to fail when they leave, because we do not provide any, nothing like Safe Supply, but even access to OAT unless they've been on it in the community. It's a policy of Nova Scotia Health that once you're in our jail, you cannot access, right? It's called, I think Dr. Risk-Cronfley mentioned that, people are just expected to go cold turkey when they're in the jail. And of course that means, you all know better than anyone that people's tolerance is going to go down once they're released. So I thought when you said when people are released to the tents, you're looking at your watch and waiting not just for them to be picked up again, but to overdose.
We're waiting for all kinds of things.
For all kinds of things, exactly. So I just think I'm astonished that policy hasn't yet changed, and you folks are doing that bridging that is just almost impossible for me to imagine, of people moving in and out of a really impossible space. Yes, sorry, please.
Yeah, no, just, on that topic too, it's very, unless you're on it in the community, and that causes issue, because if you do have a warrant out for your arrest and they know that you're on OAT or Safe Supply, they're gonna find where you're at. But there's the limits of it. I think you can only have 100 or 120.
Right.
And a lot of people are on 140, 200, 180.
So when you go in the jail, the policy has a cap.
It has a cap, yeah. But they also strip search people. They don't do it anymore, but they did it for a long time. So you get strip searched every day before and after you got your methadone. Which is very unethical. It's very illegal. They only did it for the guys. They didn't do it for the females. So I'm actually the class representative for a class action lawsuit towards that. And I feel like I know court cases can take a lot of time and money and effort, but when we're talking about these fundamental human rights, We need to push the envelope as far as we can, and you know, like I'm an optimistic guy, but I feel like we have a good chance. Like the Justice Department's already talking settlement about that case, but I feel like there's all kinds of different cases. If you go into jail and you're not given opioid agonist therapy, you know, like that could be a class action as well. And yeah, we gotta, you know, I think, and that's why it's important to work in collaborative teams with healthcare providers, people with experience, doctors, researchers, students. And I feel like that's when the most effective work gets done.
The strip search policy did change after your, right, and others bringing that advocacy lawsuit, so.
This is on a little bit of a different topic than the corrections, but I'm wondering in terms of like how often and how quickly policy shifts in terms of what is accessible for people. Like for example, dialogic carries being accessible for 1 year and then the program ends and then they're no longer accessible. So you have people that are coming into new programming and then not being able to access once those pilot programs end. I'm wondering if like what happens for those people at the end of the day when the programming ends, and then also what would be recommendations that you guys have in terms of continuing like more stable access? Would it be like a just regulation in terms of like having carries for dilaudid be something that's standardized, like stuff like that, in respect of the fact that we're also regressing in terms of safer supply, so this is like an idealized conversation maybe at this point even. But I'm really, I'm wondering about that and how it would maybe put people back into positions of becoming criminalized because they go back onto the street after their programs end. So yeah, that's my question. Very long.
Yeah, and I think I mentioned it a little bit earlier, like I feel like we have a lot of great doctors on this panel, and you know, I think it's important to find a doctor that works for you, you know, you build that relationship with them. And I know, like Mike said, there are, you know, in Alberta, which could set precedent for other provinces, but you know, if you find a doctor that, you know, trusts you and works with you and the Safe Supply program is working for you, you know, there's ways that they may be able to take you on as a family patient. And you know, I find it so interesting that, you know, if you're not a substance use disorder and you break your arm, you can go to the doctor, you can get 3 months worth of Dilaudids, no urine drug screens. And I feel like that's the way we kind of have to approach Safe Supply. I'm not saying we should give people 3 months, but you know, maybe 2 weeks, 1 week, and kind of build up to that relationship, do some pill counts, maybe some urine drug screens. But once those come back positive, then you can start to prescribe it as less of a safer supply, but more of a, well, I guess same safer supply, but maybe more of like a chronic pain approach where you don't have to ask too many questions. Like my doctor, he's been practicing Safe Supply for the last 20 years, but he doesn't think it. You know, but he, you know, he's given me Ativan, methadone pills, Vyvanse, morphine, and like he just doesn't ask what I'm going to do with it. I think he gives me a little bit of leeway, but like, yeah, and that's just because I built this relationship with him. You know, I talk to him, I tell him I'm going on a conference, and he called me right before I went to Greece, and he's like, "Do you got everything?" And you know, like it's this very unique relationship. But when I call him, what are you calling me for? I was like, you gave me your cell phone number, so I don't, like, you know, you shouldn't have done that. But you know, like I was just worried that I wasn't going to get my scripts in time. But yeah, like I think it's a really beautiful thing when you get a healthcare provider and a patient that really connect, and I think you can really push the bounds a little bit, not like push them too far, but you know, just come creative in your approaches.
I feel like that's such a sensible approach, and I think that it's great to
you want to go?
No, you don't.
Sorry, I feel like I'm talking the whole time. In Ontario, we're seeing this like roll out in live time. A lot of people are being transitioned to OAT or being offered OAT, so that's, once a day, non-peaking, it's like just, traditional treatment like methadone, Suboxone, and Cadian. But, that's it. And there's a reason why people needed safe supply. It's because those other things didn't work. So it's going to be brutal, and we'll hopefully we'll research it and see the unfathomable harms that are going to happen. To answer the question, what should we do? Well, we try to end the cessation of safe supply programs, but probably I would be in favor of moving to a regulated market. Yeah. Sure. Yeah. And there's so many ways of doing it, and it's a larger conversation. It still could be medicalized. It may, perhaps, addiction medicine doctor needs to say, yes, you can access this regulated market. I would rather not, but maybe there needs to be things like that in place so that government's happy with that. But
and pairing it with passion points.
Yes.
I think they don't have to be one or the other. You know what I mean? If I'm getting allotted, prescribed by a healthcare provider, I'm like, no, I really want to use cocaine this weekend. Well, here, go check out golf and get some comprehensively tested cocaine, right? And I feel like that keeps everybody accountable and as safe as possible, right? Because there's more and more cocaine or fentanyl showing up in cocaine, and there's all kinds of different risk factors from using unregulated supply.
I can just touch on that really quickly. Another thing that I think is really important is that as prescribers, we have, until the government does pulls like in Alberta, but we have autonomy, right? And so what we see here in Nova Scotia is there are Nova Scotia Health addiction clinics that take a long, they're still trying to catch up to some of the changes in the guidelines, whereas when Mike and I and Leah were practicing kind of independently, we just follow the evidence. And we can roll with things. We can do things like safe supply. I've actually been doing safe supply a lot longer than we've had an official program. Because you can do that, because you can see the patient in front of you, you can look at the evidence that's available, you can follow trends in other places, and you can roll with that. And so I think that although it'd be great if our health system was going to take this on and do it, I don't know that any of us really have a lot of faith in putting it all under Nova Scotia Health, because they can't keep up with what's happening in the drug market. Things are evolving too quickly. So it's important to have these kind of autonomous practices where we can evolve quickly and make decisions about carries and things like that, independent of what policy, right?
I also would kind of be lying if I said that part of my decision to get sober was out of fear that there would come a day that the pilot program would end and I would have to go back to an unregulated market, because I recognize that the chances of that transition ending in death for me is very, very real. And the other thing, since we've entered the fentanyl era, we're going to see opioids get more and more potent, because before with heroin, you had to truck in literal truckloads of it to feed a city. Then you go to fentanyl and a suitcase can feed a city, like a mega city, and then it gets more and more potent. And we used to test, heroin for fentanyl, but now we're testing fentanyl for xylazine and for more and more emerging things. And so if we don't catch up, if we are not proactive, then we are always going to be reactive, and we're going to get bogged down. There is never going to be an end. There's always going to be a new emerging, scary, more potent version of whatever there is, because it makes it easier for smugglers to get it in.
Hi everyone. Lovely chatting, lovely discussions. I think one of the core dynamics underplaying all this is kind of that notion of building kind of compassionate kind of platforms, deeply evidence-based, best practice approaches, reducing stigma, reducing kind of, or dispelling myth. We've kind of started to do that around homelessness, I think, in ways that if you looked here 10 years ago, we wouldn't think we'd get this far. Are there places that are doing that with sacred supply? Like, are there countries that can be models to what we can emulate?
Switzerland. Switzerland has been the pioneers in like heroin-assisted treatment and whatnot. And I don't think we particularly need heroin-assisted treatment on the East Coast, but I think just with the policies, the procedures, how they kind of do conflict resolution. But there's a lot of European countries that provide some form of, I wouldn't call it safe supply, I'd call it more of like a medication-assisted treatment, but not like methadone, more like heroin-assisted treatment. I think I even heard that there's a country that's providing cocaine over there. It might be Switzerland or Sweden. So I think there are some good programs that are operating. But I also know that the drug supply over here is so different that it's hard to kind of, it's good to model it, but like I feel like we would have a bunch of additional challenges just because of the xylazine, the benzos, the niazines. But I think even in the country, in BC, in Ontario, there's a lot of good models and programs that we could adopt.
One of the fundamental problems we have now is that prescribed safer supply, as we're talking about it and practicing, is criminalized in the US and England and Australia, which are three of the big places where like addiction treatment innovation comes from. There's criminal laws restricting physicians from prescribing opioids to people with opioid use disorder, and then they carve out exceptions for methadone and Suboxone, and the rest is all criminalized. So all of even the like routine options that are in our guidelines, like the slow-release morphine, KD, and OAT, is criminalized in the US. So we won't see international evidence, we won't see best practice models, and this like prescribed tablet safer supply really is a Canadian innovation. And part of what worries me is that the progress that's been made on safe supply and largely on decriminalization has been aligned with other social movements that are also facing blowback. So, well, for safe supply, it was really COVID, and suddenly it's everybody's job to keep us safe, but also to stop the vector of disease in the community. So safe, we suddenly had money to support people in hotels and provide safe supply so that they could isolate. It's like, well, it's a bit of a different conversation than just people dying from overdose. And decrim in BC and in Oregon has really been a social justice movement about decarceration, about racist inequities. And that's all faith, is it a coincidence that the anti-harm reduction politics is the same as the anti-trans politics, is the same as the anti-EDI politics, and the blowback is universal, right? So I guess I've rambled a bit here, but we're limited in terms of international examples, and we will be because it is criminalized. And I worry as the politics are changing here that this is the leading edge of this, and it's going to be curtailed, and then this innovation is going to be smushed.
There was one person just behind you, so two people. Yeah, go ahead.
Hi, and I'm willing to take this offline because I had questions about the approach to this population once they enter our acute healthcare system, and that I probably could ask 10 questions, which I'm happy to do in this audience, or if you would like to take it offline. But I'm getting so many questions about this topic, not just safe supply, but approach to patients who use IV drugs. But I could even just limit it to safe supply. How to identify these patients, concerns about how to prescribe, if it should be pills or IV, and then should the nurses be witnessing them taking these pills, because they're not really allowed to walk away, and what is the approach if we don't have the wraparound services in the acute care system? The mental health approach is very different than the addictions approach. So we can't often get mental health services support for these patients. There's fears that patients will, if these drugs are supplied in our ED, that they may come to our vastly overcrowded EDs instead of going to their safe supply. And if they get them in the ED, like if they come for a legitimate health reason and then they get opioids, are they then going to overuse or divert? Like, there's so many questions. And I feel like it's maybe a whole talk on its own, but
A talk that we definitely should have.
I need answers to these things because, and there's no policy for the nurses. I know it's under development, but I think that's still months away. And this, I needed an answer yesterday.
Yeah, we all did.
We, like, four of us work on the inpatient addiction medicine consult service, so.
Yeah, but they don't come to mind.
Exactly, not yet. So we're working on expansions over to the Dartmouth General Hospital. But mostly I say that because the issues that you're facing, we also face.
Yeah.
And so we definitely can take this offline,
Okay.
figure out answers for you.
Should I email one of you or?
Let's just talk right after, we'll talk right after this. Not with all the questions, but figure it out.
Sorry, but I email them with everyone.
And if there
So
are
I send
any,
a group email.
sure.
Is that right?
Yeah.
Okay.
And if people have questions about anything, getting PowerPoints or this or that, you can't remember, can't find, just remember Dalhousie Health Justice Institute, and I'll put you through to whoever, you might need to talk to. You also had a question?
Yeah, thank you, all of you, for your talk. I think in the wake of what you were saying, Tommy, about how we aren't going to be able to look internationally for guidance, and the fact that we're coming off the heels of a municipal election, and I think about to go into a provincial election, I'm just really curious, what interest have you felt, or how shunned have you felt, both from a provincial government engagement standpoint and a municipal government engagement standpoint in the work that you do within HRM in Nova Scotia? And if you can be blunt, I think that would be great to hear.
That's the only language I speak.
I was just gonna go quickly on like the supervised consumption sites. Like we opened these back in 2019. We had no funding. We were selling T-shirts. We sold the old Direction 180 bus, and we got it operating. And it was actually in my name, which I thought was ironic because I have a little criminal record. And I remember I put Tommy's name as like the main person, and they called me and were like, well, is Tommy going to be there every day? And I was like, well, I don't think so. And so they put me as the responsible person in charge. But when we transitioned to the Progressive Conservative Party, they still funded the sites. They still fund 2 sites. It's not a lot of money, like it's pretty minuscule, but it is. They operate Monday to Friday, 9 to 5. And I think it's interesting because there's no media about our sites, right? And especially what's going on in Ontario and all that. Like, it's pretty quiet, and I feel like it's interesting because I think we could collect a lot of cool data on why people are using these sites. A lot of people use Safe Supply, and I think it would just be really helpful for the data to support these sites. But it's very, like the geographical climate on these sites right now, if the Conservatives get in BC, they want to shut down all the sites, right? So I think we have a unique opportunity to examine these sites, collect data, publish, and kind of fight back towards this narrative of what's happening in other provinces.
Locally, from a Safe Supply standpoint, there is a Deputy Minister of Mental Health and Addictions. So we know he's a physician. And we've been able to engage in meaningful conversation with him, which he then brings to the minister, which is the Progressive Conservative government. They've been writing opioid response plans. Tablet Safe Supply isn't a part of that plan. Our funding is not secured through, in part it's slightly provincial, obviously physician funding is provincial, health services through Northern Community Health Center is provincial, but there's also other, non-government organizations that help fund us. So we're a little bit immune to government funding. Now, were they to say we're not going to fund other programs within your health center because you have a Safe Supply program, that would be one way to screw us.
Yeah.
so the provincially, the interest from what I've been hearing, and none of this is official, has mostly been towards observed models. So there's an appetite for IOT, or heroin-assisted treatment. With all of the barriers that exist with those, I think there's a role. It's one of the interventions there that is absolutely an important wedge in the spectrum of what we try to do. But there hasn't really been much any conversation about ramping up or investing in tablet safe supply.
And we just heard like a lot of these people that are on injectable opioid agonist therapy, they don't like it half as much compared to the people that are on Dilaudid. Like in the Vancouver downtown east side, people were getting 300 milligrams of hydromorphone and they were trading it in for 8 milligrams of Dilaudid. So that's like, you know, like it's like 200 milligrams short of what they would have been getting. But like, you know, and I always say this, like I know I'm the only drug user here, and you know, I've experimented with a lot of different drugs, and I know we all know drugs on paper, and you know, we've done a lot of great research, but until you've, you know, actually tried those drugs and see what they do for you, and that's why we need to listen to the experts, because I completely believe, like when I was talking to the person at the OPS, they said, I hate this liquid hydromorphone. Like I would trade it for pills any day of the week, right? And I think it's important to collect that information and see why that is happening.
I think that I just want to respond really quickly because I think, yeah, so far we've been pretty protected, I think, politically. I think we've had no one's really knocking down our door to like ask how they can support us, although if anyone's running for anything, we'd be really welcome to that. But we have seen like municipal elections in Cape Breton, for example, like the mayors in the Sydney area were really like some of their platforms were to shut down the Ally Centre, which is the only like harm reduction service, health service in that area. So it's a problem. I would say the bigger issue, and I would encourage all of you as you know, citizens of Nova Scotia to really demand our government look under the hood of Nova Scotia Health, because that's where a lot of things really get tied up, and actually those are the places actually that aren't asking for our expertise, and then we're trying to have to fiddle or get ourselves in the room, or you know, and I am employed by Nova Scotia Health, and I've said this in many times, and I still have a job, so there we are. But because it's because of the accountability piece, right? And it's like if we're going to have a mental health and addiction program, we actually have to have equitable leadership for both of those things, and in corrections, somebody who's writing the policies for addiction actually be an expert in that and practice that. And that's Nova Scotia Health. So we have to hold our provincial, you know, elected officials accountable to look under the hood and, you know, support the people. Like this is an aside, but is very much related to this. The burnout in the healthcare system has nothing to do with patients and the long hours. I mean, it probably has something to do with that. We all signed up for that. The burnout is in the system. The system that we work for does not care for us who are trying to care for the people, and people take care of people. Communities take care of people. All of us take care of each other, and the system we work in is just really impacting all of that. And you know, you'd have to go into any Nova Scotia Health institution, and that's visible immediately. So I think that those pieces and holding those leaderships accountable for, well, where is the harm reduction policy for the hospital? What's happening in the jail? You know, why aren't we funding this? And why did our mental health and addiction money not go to, you know, for fund ACT programs and stuff, the things that we need? And so that's where we need the voice, and whatever elected official is gonna, you know, be behind that, I'm all for it. But,
wow. To bring this to a close, like we started off by saying something like, you know, we're going to get grounded in the facts, and we're going to put aside, you know, some of those the politics. And I think Matt Herder's intervention was really wise to say, no, this is politics. And you know, Leah's last piece about caring for each other, coming together across lots of differences. I love that there's people in this room who haven't seen, you know, in this room, at least I myself, before, and coming together, you know, from all kinds of all kinds of paths have brought us here, and that really is politics. So I hope we can continue these conversations. And like I was trying to sort of say for a second there, if you do go away and you're like, who are those people again? Or I do have this follow-up question, or hey, maybe I'd love to see that slide that had really interesting data or whatever, just get in touch. It's Health Law Institute somewhere you would have, or Health Justice Institute somewhere you would have seen a sign about that. And if you just have that, you'll be able to find us on the Dow website, and you can find me, Sheila Wildman, and I'm happy to put you in touch either with East Coast prison justice types or you know, folks who are working in health justice otherwise. So first of all, thank you for coming, and please join me in thanking our incredible panel.